So hi everyone, thanks for coming along. I'm sure people will keep coming in over the next couple of minutes or so. My name is Brio Lehman. I'm a lecturer at the Statistics Department at UCL, and this is an edition of the Statistical Methods for Health Equity webinar series, which is a monthly webinar series focusing on statistical and machine learning methods that have the potential to promote health equity. So for example, methods that can shed light on the complex factors underlying inequalities or fairer algorithms that appropriately take into account the biases that exist in biomedical data sets. The webinar series is co-hosted by the Alan Turing Institute, specifically the Health Equity Interest Group, the UCL Stats Department, where I'm based, and Data Science for Health Equity. And Data Science for Health Equity is a global community of experts and enthusiasts working at the intersection of data science and health inequalities. And the broad aim of the community is to ensure that the latest research and innovations in data science, ML, and AI improve everyone's health, and especially those in underserved populations. So if this sounds like something you're interested in, then there are a few ways to get involved, which I will post in the chat very shortly. Today, it's my great pleasure to welcome Dr. Ira Ktena. Ira is a senior research scientist at DeepMind, working on deep learning for healthcare. And her research interests span a broad range of topics with a strong focus on model robustness, fairness, and multimodal representation learning. Prior to that, she worked on graph representation learning for neuroimaging at Imperial College London and Harvard Medical School, where she collaborated with the stroke group at the Massachusetts General Hospital on early outcome prediction. And without further ado, I will pass over to Ira. I'm very much looking forward to the talk. Over to you, Ira.
Thank you so much for the introduction. So today what I'm going to talk about is work we've been recently doing at DeepMind with a great team of collaborators, and is essentially covering how we can leverage powerful diffusion models in medical imaging in order to build fair, more robust, and private models. So the first line of work that I'm going to cover was done in collaboration with this great team of individuals, and we shared it on arXiv back in April. So in this work, we consider the following two challenges in medical applications. One is fairness, and this arises as we may not or probably don't have a balanced distribution over sensitive attributes, for example, age, sex, ethnicity, and so on. But it can also rise because we don't have always the equal representation of different geographical locations or hospitals, for example, that may have different acquisition protocols. And then the second challenge is distribution shift. So this arises when we deploy a model in new settings, which leads to a drop in performance. And this we often observe when there is like a performance gap between deployment, model development, and model deployment. So for example, label shift may arise from deployment in a new geographical location with different demographics, or it may occur due to shifts in the camera or the capture process. And a different kind of shift can arise when the reference point of the capture process changes. For example, we have images captured by clinician, and then we have we want to use the model to evaluate images that are captured by the individuals themselves to do some kind of early assessment of their conditions. Relatively recently, this group at MIT, led by Marjir Ghasemi, looked at performance disparities in different chest X-ray datasets, and many of you in the audience are probably familiar with this work that essentially looked at underdiagnosis biases for different demographic subgroups and intersections thereof. And they also looked at proxies of socioeconomic status, like, for example, insurance types. what they were able to show is that they could identify groups that are consistently underserved by the developed algorithm, corresponding to younger Black and female subgroups. So this was, of course, only one of the works that have shown such results. There have been similar studies in other modalities and looking at different attributes that are leading to these sorts of biases and performance disparities. Now, there have been also quite a few works that have tried to understand and interpret why these kind of disparities emerge. These are kind of just two examples that can be seen as different sides of the same coin. One is shortcut learning. So essentially how the model is kind of leveraging information that causally shouldn't be linked to the diagnostic label in order to because there is correlation between this attribute and the diagnostic label. So in this work that is about to be shown in Nature Communications, they show that the degree to which models encode for a sensitive attribute is actually a poor measure of the degree to which that attribute may be used. So this supported previous work that demonstrated that the presence of sensitive attribute encoding by model may arise incidentally. So they rather focused on the encoding itself. They don't focus on the encoding itself, but to the degree to which the fairness of the model's predictions depend on this encoding in order to diagnose how fair a model is and try to also mitigate unfairness. There's more recent work by a group at Imperial College where they looked at subgroup separability, and this is about to appear at the MICAI conference this year. So what they've shown here is they use this split metric that essentially measures information regarding sensitive attributes in the representations. And they juxtapose that to subgroup separability. And what they showed was that performance and fairness of models trained on biased data and bias with respect to, let's say, one subgroup has different performance compared to lower normally performance compared to a more prevalent group. They show that this depends on subgroup separability. And when separability is high, then models learn to exploit the sensitive information and the bias is reflected by strong subgroup differences. But then when separability is low, then models cannot exploit sensitive information. So subgroups will perform more similarly. Now, in order to improve robustness and fairness, there are different stages of the development pipeline that we can intervene and in different ways. So this is, of course, not an exhaustive or complete list, but is an example of which stages of the process of deploying a neural network we can consider fairness and robustness of the model. So if we imagine the path of creating and deploying a machine learning model, we have various stages in which, during which we can try to improve those two aspects that are often actually not tackled together. But in this work, we try to tackle robustness and fairness with one single method. So first we collect the data. And here is perhaps the most effective way of improving fairness and robustness by collecting more representative data. So I guess nobody can question that this is something that we should all try to do, really increase the diversity and representation of the data that we are developing our algorithms on. However, this is not always possible for different reasons. And one reason can be that certain diseases are much more prevalent in certain geographical locations or certain skin types or at certain ages. We can also try to develop algorithms or calibration methods to improve robustness and fairness. But this requires a good held out data set and evaluation setup to properly track progress without overfitting on the given evaluation setup. And finally, when we deploy the model, we will see how the model does indeed impact end users in terms of fairness and robustness, which will inform future iterations of model deployment. And then as we move from left to right, we are moving from model agnostic to model specific approaches. So the approach that we proposed in this work is somewhere in between collecting data and training the model. We use a generative model that is trained on labeled and unlabeled data that are often abundant in the medical, much more abundant in the medical setting than labeled data, to create synthetic samples which will be used to augment the training setup. And we view this as a similar approach or an alternative to heuristic augmentations, but in this scenario, our augmentations are learned. The benefits of this approach are the following. The synthetic data may be helpful as we get more better model data density. So that's why with diffusion models, we can get better quality data than we used to be able to develop with generative adversarial networks, for example, and potentially compose attributes existing in the dataset to create new samples. So, for example, we can imagine acne on new faces, even though that has limitations, of course. We can also, and this is the most important property that we try to leverage, that we modify the distribution of properties or attributes so that we create more synthetic samples from low data regions. A more pragmatic benefit is that we can reuse the synthetic data on any downstream model, as opposed to having to calibrate each new model. And then finally, this synthetic data can be used in conjunction with other improvements in the pipeline. So it is not mutually exclusive with other approaches that try to also improve the robustness of the model. So of course, this is not the only attempt to use generative models in the medical setting or to explore whether we can improve robustness or fairness of models. And one interesting example is this Nature Digital Medicine paper, where the authors explored the medical knowledge captured by a domain-agnostic GLIDE model. GLIDE is a diffusion-based text conditional image synthesis model that was developed by OpenAI. And the authors showed that some level of medical knowledge is already captured by these large models, but of course, insufficient for it to be useful in any meaningful task. So you can see on the right-hand side here on the slide how limited the utility of the model is without proper conditioning or fine-tuning. So to summarize, proper fine-tuning and conditioning is essential for generating useful and high-quality images. So to reiterate, what we are not saying in this work is that synthetic data is a solution for bad data. We cannot imagine what is not there. So we cannot imagine parts of the data distribution that we have never observed. And additionally, we are only as good as our evaluation. For example, we must ensure that the evaluation set is reasonably balanced and represents the sensitive attributes or the properties of interest when we are looking at, for example, different hospitals. And finally, generated data cannot be used for evaluation. So using only generated data for evaluation can be very misleading and lead to conclusions that do not generalize. So how does our method work? First, we train a generative diffusion model given the available labeled and unlabeled data. we assume that labeled data is available only for a single source domain, while we have access to additional unlabeled data that can be from the source domain, so in distribution or out of distribution. But we don't have access to any labeled data out of distribution. We then either condition the model, the diffusion model, only on the diagnostic label, or on both the diagnostic label and the property that we care about, for example, hospital ID or sensitive attribute label. Then another important limitation of our work was generating images at high resolution. So there are modalities that we explore in this work that require high resolution images for diagnosis. That means higher than 96 by 96 resolution. And that requires training and upsampling diffusion model in a similar manner to the underlying low resolution model. And then both models need to be, so both the low resolution and the upsampled diffusion models need to be trained with the same conditioning vector. Then we sample from the second stage involves sampling from the generative model according to a fair distribution. And the third step involves combining the synthetic and real samples from the generative model with labeled data from the source domain and training and downstream classifier. So maybe just like to quickly recap how diffusion models work for those of you that are not familiar with them. They are involve a forward diffusion process in which level of noise is added at across a number of steps to an original image. So starting from a clean data on the left-hand side, we incrementally add more and more noise according to a diffusion process, and that leads to a fully noisy image. And then we try to reverse this process by denoising the noisy image. So for each training step, there is a time step is sampled between 0 and the maximum number of steps, which is for good quality generative model is in the order of thousands. And then the way this is trained is that at each step, for each step that we sample, we try to predict the level of noise that was added from the original image to obtain this noisy image. So two challenges that we have when using this method is, first of all, how to sample labels. And to do this, we sample uniformly from the sensitive attribute distribution and preserve the original diagnostic label distribution in order to preserve the original disease prevalence. So that means that if we have, for example, skin, like a dermatology data set that is more skewed towards certain set of conditions like acne or psoriasis, and then we have fewer samples of melanoma, because this is less prevalent in the population, we're not going to alter the label distribution, but we are going to sample uniformly across, for example, skin tones, if we have multiple skin tones represented in the data set, with a goal of improving the fairness of the model. So sampling multiple times from the generative model allows us to obtain different augmentations for a given condition and property, and increase the diversity of training samples for the downstream classifier. Then the second challenge that we have is how to combine the synthetic and the label data from the source domain. And this is something that we treat as a hyperparameter then that changes across the domains that we explore. So before getting into the results on real data, here we consider a toy setup to build an intuition for why synthetic data may be useful. In particular, there are two potential reasons. One is better density estimation, and thereby data augmentation and compositionality. This toy example focuses on the former, so data augmentation. We consider three mixture GMMs and a three-mixture GMM, where we have the true distribution on the left-hand side. On the right, we show an animation of fitting a generative model to the labeled and unlabeled points as we gather more unlabeled data. With more unlabeled data, what we see is that we are better able to capture the underlying true distribution and easily differentiate the modes of the distribution. We are not showing here, but we have investigated if this improves the performance of a downstream classifier, and under certain conditions, this is indeed true in this setup. So the three medical contexts that we consider and that we test this approach on include histopathology, chest radiology, and dermatology. So these are in increasing degree of difficulty. So each of these modalities has its own challenges. We consider histopathology as the easiest because images are lower resolution and are relatively more homogeneous. Also, is posed like a binary classification problem. So we label patches from these whole slide images as including cancer versus healthy cells. And the next most challenging data set is the chest radiology data set that includes CheckSpurt and NIH X-ray data sets. And this is high resolution compared to histopathology, but again, images are much more, the presentation of the images is much more homogeneous as a whole compared to the dermatologist data set, which is almost looking like natural images. And we have also a higher number of conditions. We have almost 300 different conditions that are grouped into 27 conditions that we look more carefully at. And the examples on this slide are examples of different generated images for different conditions for these three modalities. And you can see that for all three of them, they are looking, at least at the first glance, they are looking quite realistic and capturing characteristics of the conditions that they're supposed to represent. For the histopathology setting, we use the chameleon dataset that is part of the WILDS challenge for out-of-domain generalization. And this is the task there is to label whether there are tumor cells in the images from 5 different hospitals. We have 3 training hospitals, 1 out-of-distribution validation hospital, and 1 out-of-distribution test hospital. The tumor and non-tumor labels are balanced for each hospital, and the image resolution is 96 by 96. So to set up our experiments, we use the dataset as follows. We use the out-of-distribution validation dataset for validation, and then take the in-distribution validation and out-of-distribution test set for evaluation. Note that there are unlabeled data as well, which includes hospital information, but not the diagnostic label. So for the in-distribution data sets, the hospitals, we look at the accuracy across the hospitals as well as overall, and performance on the out-of-distribution test set. In order to understand how model performance varies, we also consider skewing the number of samples for 2 out of the 3 in-distribution hospitals, and explore whether our model can perform well under more extreme settings. So as we skew the data set more and more against those hospitals, how does performance change? So here we show some examples of generated histopathology images when conditioning the diffusion model on positive and negative diagnostic label with respect to tumor. We can clearly see the differences between the 2 classes Images generated for the label tumor look more like epithelial cells with larger nuclei compared to normal cells, and healthy cells look like normal lymphocytes. It is worth noting that the results shown on this slide do not use any real data and only synthetic data. So the baselines that we consider include a model, a ResNet model with no augmentations or pre-training. So there's no pre-training on a different data set. And there's a model, ResNet model trained with color augmentations that have been shown to be very powerful in out of distribution, in the kind of adult distribution generalization setting. And then we show different versions of the proposed approach, conditioned on the diagnostic label or both the diagnostic label and the hospital ID. And combining this generative model with color augmentations on top as well. So we evaluate the results in two settings, as I described earlier, the less and the more skewed. So on the top, this panel corresponds to the less skewed setting. So we have 1,000 label samples from hospitals 3 and 4, whereas this is the more skewed setting where we have only 100 samples from hospitals 3 and 4. On the x-axis, we are looking at accuracy overall, and on the y-axis, we are looking at performance gap between the in-distribution hospitals, which we consider as our fairness gap. So the best place to be is the bottom right corner, where our model is more accurate than the baseline, indicated with the dotted lines, and is also fairer than the baseline on the y-axis. So we also evaluate the models out of these same baselines out of distribution on the validation set and on the test set. And what we see is that using synthetic data, either with label and property conditioning or just label conditioning, so we're looking at red and green lines here, so that always performs better than the color augmentations. But then what really makes these models perform the best is combining them with the color augmentations, and then we also see that benefit in the out of distribution accuracy of the model. So in this simpler setting, we already see that diffusion models can actually improve results quite a bit both out of distribution, but also in terms of improving the performance gap across hospitals. In the radiology setting, as I mentioned, we're using CheckSpot and Chest X-ray 14, the NIH dataset. So we train purely on the CheckSpot dataset with no unlabeled data. So the setting is a little bit different to before. We don't have access to any unlabeled data. And we have higher image resolution of 224 by 224, which means that we need to also train an upsampler. And then we only evaluate on the NIH dataset, or chest X-ray 14. And what I'm trying to show here with these heat maps is that this is a normalized co-occurrence of the conditions, the 5 top conditions that we are looking at. And we can see that there is a shift from the training data set to the evaluation set. That is, we consider out of distribution because it's different sets of hospitals, and also it's according to different criteria that these diagnoses have been made. So we can see that, for example, while in the training data set, 43% of the patients with cardiomegaly also have edema. This is a much lower number in the evaluation set. So there is actually quite a strong label shift there. And so moreover, we also have like differences in the demographic attributes that we're not showing here, where the evaluation set is more skewed with respect to sex, for example, than the original training set. The baselines that we consider here are again a big transfer resonant model. So there is pre-training here on a larger corpus of natural images, and this pre-training can be on two different sets, ImageNet 21K or a much larger JFT data set that includes 300 million images. And then we compare random augmentations that have also been shown to be quite powerful, and combining those with ImageNet augmentations as well. So again, on the x-axis, we are looking at top-level performance. Here we look at area under the ROC curve, because this is what the Checkspert leaderboard is capturing as well. And then on the y-axis, we are looking at fairness gap. So in this case, we are looking at sex differences. And the baseline that we consider is a model pre-trained on JFT. And then what we see, and then we also, on the left-hand side, we have the in-distribution data set, so the held out Checkspert evaluation set, and the out-of-distribution chest X-ray 14 that we never observed during training, either the diffusion or the downstream model. So what we see is that with label conditioning, which is the brown method, the model highlighted with the brown color, we have benefits both in terms of fairness and in terms of area under the curve. But these benefits are much more prevalent in the out-of-distribution setting. So again, we see kind of a similar trend with a histopathology setting. And here are some examples where we look at different conditions, images generated for different conditions, starting from consolidation, where the right lower lobe is too white, and it appears as air is replaced with something else, like blood or edema fluid, to cardiomegaly, which is probably the most obvious, where we have a high cardiothoracic ratio, and so on. Moving on to the dermatology setting, this is actually the most challenging one, because we have both a demographic shift and a label shift. And we focus on the analysis mostly on the high-risk conditions. So we train the generative model so that it can generate all the different conditions. But then when we look at how performance is impacted by the synthetic samples, we focus on this on sensitivity for these high-risk conditions, because we really care about not harming performance for those. And they're also the ones that are underrepresented in the original training data set that you can see here. But then for the two out-of-distribution evaluation data sets, they're actually much more prevalent, as you can see with these histograms. So we explore different versions of and levels of skewness across demographic axes, including age, sex, and skin tone, using the labels in the dataset. And here I'm showing an example on sex, where again, the top row is looking at the less skewed setting. So we make the data set skewed towards a particular demographic attribute by removing samples from the training set from the underrepresented attribute, agnostic to the condition distribution, so the diagnostic condition. And on the bottom corner, so in the bottom line, we have the more skewed setting, where we have as few as 100 samples from this underrepresented group. And here, the total set is around, the total data set is around 12 to 15,000 samples. So if we only have 100 samples from the underrepresented group, then it's a highly imbalanced setting. But that's not the case, of course, in the evaluation sets, right? This is something to clarify. So here, label conditioning and label property conditioning. So the purple and gray colors are the ones that correspond to our method. And then the other ones are different baselines that we consider, like augmentations or an oversampling baseline to make the data set more balanced. And we consider model pre-trained on the JFT dataset as our baseline that we compare all these methods against. So what we observe is that in distribution, our models are the most performance in terms of high risk sensitivity. So here on the x-axis, we have high risk sensitivity, and do not hurt the performance and do not hurt the fairness here. So we don't see an improvement on fairness in the in-distribution setting, which is the left column, while in the right column, where we look at out-of-distribution performance, our models improve both the fairness gap and the high-risk sensitivity quite significantly. So especially in the more skewed setting, you can see that we have 7 times improvement of the gap with respect to the baseline. And this is true in both settings, that in the more skewed setting, then we see more of the benefits. And results are quite similar across the attributes that we consider as well. So not only for sex. Now, when trying to understand why this actually works, we evaluated the utility of the generative model in a purely quantitative way. But even though generated images were not intended to be used in isolation, we thought that it was the right time to also receive some feedback from clinical experts with respect to aspects of the condition that the generative model is conditioned on. So we ran a small-scale review of the images with 3 different dermatologists, and according to their claims, images were to a large degree diagnosable. And in some cases, images were more canonical of the condition, meaning that the original training set, there were instances of body parts that are not characteristic of the condition, for example. And it's, again, important to stress that we do not intend to use these images for training purposes of clinicians or for evaluation, but this was purely to evaluate whether the downstream effects that we see in our diagnostic model are also linked to features that clinicians would also pick up when making their diagnosis. So in the in-depth analysis, we also looked at how synthetic samples align distributions better and reduce spurious correlations. So this is just one demonstration of how diverse images are for a single condition, that we're not just by sampling again and again from the model, we're not just obtaining images that look exactly the same. And this is for a set of 6 conditions. We have 4 samples per condition. So you can see when the condition is displayed on different body parts, then we have samples from that look like different body parts, but there are some that are mostly, for example, on the scalp. So there we will have like less variation with respect to the body part, of course, but we will have, again, diverse images with respect to severity of the condition or skin tones, etc. So yeah, here is just showing if we focus on the second column of the top 3 accuracy on synthetic images, then dermatologists had almost 68% top 3 accuracy amongst the 28 conditions, whereas the equivalent number for this same set of conditions on real images was 67%. So they're actually very much comparable. The only caveat is that only 50% of the images was considered as of sufficient quality. But when it was of sufficient quality, then dermatologists were actually quite confident. So this is a score out of 5. So on average, they gave a 4.1 score out of 5 in terms of confidence in their diagnosis. And this is just like a ballpark number, 75% for top 3 accuracy from a more diverse set of dermatological conditions than the ones these 2 numbers correspond to. So here what we're showing is that we are able to generate canonical images even if only a handful of examples are available that were rated with high confidence. So for this condition, we only got 5 images out of the whole training set that had like high confidence, in the sense that we had multiple raters ranking conditions, and then we aggregated those sets of diagnosis across the labelers. And let's say if they all said that, if there was consensus that the top condition was melanoma, for example, across 3 raters, then that would lead to high confidence in melanoma diagnosis. But if one thought that it was a different condition, then that would reduce the confidence level of the aggregated diagnosis. So on the left-hand side, we show synthetic images of the melanoma. It's worth noting that the anatomies are not always very realistic, like in this example, but in most of the cases they are realistic. And here we had to black out some parts just to avoid, disclosing any potentially identifiable information that existed in the training set. So yeah, and then we also show the nearest neighbors on this panel, on the right-hand panel, of these synthetic images in the training set. And the reason why we run this experiment is to show that we are not just memorizing samples from the training set. And this is why we do this nearest neighbor analysis here. Then we look at, after projecting each data point from the input space to the representation space, we compare the distributions in terms of maximum discrepancy. And that allows us to compare representations for the data sets to those from heuristically augmenting the data set and synthetic data. And what we observe is that we had lower MMD for length augmentations by almost 20% in comparison to heuristic augmentations. which led us to the following conclusions. First of all, that data augmentation has a significant effect on distribution alignment. And this justifies the improvement on out-of-distribution performance by learning better predictive features rather than capturing spurious correlations. And that generated data helps the model to better match different domains by attenuating the overall discrepancy between domains. And yeah, so that we only learn features that might conflict with learning spurious correlations that are helpful for in-distribution performance, and that's why we see smaller gains in the less skewed settings. So I'm going to skip this slide to just briefly talk about private synthetic data. So this is another line of work where essentially we want to make actually generative models useful in a wider context. So we don't always have access to the training data from a particular hospital to protect information of individuals, or we cannot always aggregate information from different hospitals in one place, but we may still want to do model development, for example, that reflects kind of the characteristics of the data that is sitting in the hospital that we don't have access to. And this is what led to this project around private synthetic data. And this is with this set of collaborators at DeepMind. And essentially, the goal is to avoid leaking information from synthetic data generators. So we only started scratching the surface of that in the medical setting by looking at the Chameleon data set, because it's lower resolution and it's also, as I mentioned earlier, is much more homogeneous. So the task is already familiar. And here are some examples of models trained with differential privacy. So for tumorous images and healthy images, and then we increase the resolution. So these are generated at 32 by 32 resolution. And then we use an upsampler that has been trained on completely different data, non-medical data, to increase the resolution of the images. So now how can these be useful? So they can be useful for hyperparameter selection. As I said, we want to find class of models or hyperparameters that are better suited for a particular population in a certain hospital, but we don't have access to that data. We can get access to a generator or a DP generator of this data, and then tune the different classes of models. Here we're looking at ResNet, VGG, and wide ResNet in the different colors. And each dot is a model trained on synthetic samples and evaluated on synthetic or real samples to see if the two correlate, essentially. And we see that actually when training on synthetic samples and evaluating on either of those, we can actually get a relatively good feel for how well the model, by testing on the synthetic samples, we can get a good feel for estimate of how well that corresponding model with the specific hyperparameters will perform on real samples. This is what we're trying to show here. And then even more so, let's say if we only have, if we train on real samples versus training on synthetic samples generated by a private data generator, but then we evaluate on the real samples, then we almost have perfect correlations, which means that we can use these synthetic samples to develop to select a good enough class of models with a good set of hyperparameters that we then know how it would perform when trained on the actual real data. So overall, one major advantage of synthetic data is that we can reuse it. Once generated, we can use it for different sorts of tasks. It's a scalable approach. So if we have a perfect generative model, we can perform perfectly under a fair distribution. And as generative models improve or the amount of data increases, so should our approach also improve. And we can utilize private data sources by combining synthetic data with privacy preserving techniques. And this can be a very powerful tool in medical imaging to augment smaller public data sets, which of course comes with its own risks. In terms of limitations, we cannot track performance on sensitive attributes that are not tracked or recorded. And then also the classes that or the buckets that we use may have their own limitations, like the Fitzpatrick skin tone or, biological sex sometimes. And in terms of when having transparency on handling synthetic data, we can mitigate this by tagging and identifying when a synthetic image has been added to a database, especially when considering to reuse the data set in different settings or by different practitioners. And yeah, one major risk, I guess, is overconfidence in the model, bias in the training and the evaluation set. But yeah, I should leave some time for questions, I feel, as well. So I'm going to conclude here. Thank you so much for your attention.
Thank you, Ira. And I'll applaud on behalf of everyone. People I can see doing the applause emoji in the chat. So yeah, we've got time for questions. So either pop your questions in the chat or raise your hand. I'm going to stop recording in case people would prefer their questions not to be recorded.